Well, hello and welcome to this VIA medical webinar titled Monitoring Respiratory Mechanics, Drive and Effort. We are delighted to have you with us today, and we're honored to have Professor Felipe Damiani join us today as our speaker for the webinar. Um, Following the presentation, we will have the opportunity for a Q&A session. If you have any questions, either throughout the presentation or at the end of it, please feel free to write them in the Q&A box, which is available to you, and we will make every best effort to answer all of those at the end. Without further ado, I'd like to hand over to Professor Damiani. Over to you, and thank you.
Hey. Hello, everyone. Thank you for this invitation. It's always a pleasure having this kind of webinar to discuss different aspects of mechanical ventilation. So, in the next minutes, the idea is to mainly discuss or to understand what is the importance of monitoring the breathing effort in patients with mechanical ventilation, and also to discuss different techniques to monitor respiratory mechanics, drive and effort during assisted mechanical ventilation. So just to begin with, the idea, just to remind you that when we have a patient admitted to the ICU, um, in the very acute phase in terms of the ventilation, is that we have a patient with high ventilatory support, high sedation, and the patient is in the ventilator is who control most of the ventilation. But as soon as the patient is evolving and is getting better, we start decreasing ventilatory support, we start decreasing sedation so that the patient start awakening, so that we now begin to sort of transition phase when the respiratory drive of the patient is getting high, is getting to normal values, and then both mechanical ventilator and the patient is trying to control the ventilation. And then when we are almost ready just to extubate our patient in a more assisted and spontaneous phase, is most the patient who is controlling the ventilation. This is so important because during the passive mechanical ventilation, we are used to learn different concept of mechanics, and it's a little bit easier. But when the patient is starting to awake and is getting try to breathe with the ventilator, the things are more complex. We have more kind of different types of patient ventilator desynchronous, and that's why the monitoring the effort is really important. So why we should monitor the respiratory drive and the effort in these kind of patients? Well, because there is some and actually now huge evidence about that animal and experimental and preclinical experiments that an inadequate respiratory drive and effort, either too high or too low, can have different consequences on lung injury, myotrauma, or diaphragm dysfunction. Also, can affect different or can have poor patient ventilator interaction, reflecting different types of patient ventilator desynchronous. And of course, if this is all together, we can have a winning failure and it can affect the patient outcomes. So, how is this that the excessive or the patient ventilator patient effort can affect or can produce a further lung injury? This is the concept that we know as patient self-inflicted lung injury, which is explained that when we have acute phase, acute context of inflammation, hypoxemia, hypercarbia with lung edema and different inflammatory contexts, where the patient is going to have increased respiratory drive, increased respiratory effort, that will lead to inappropriate or excessive breathing effort and excessive stress and strain to the lung parenchyma. It may also have produce some pendulum phenomena. We are going to discuss that a little bit in the next slide. And we can have excessive effort mixed with some desynchronies, especially in mechanically ventilated patients. We have this double triggering or breath-taking desynchronies when you can have double tidal volumes, and therefore you can promote this vicious circle in this inflammatory context, and patient can have vigorous efforts and still and produce more and further lung injury. So what is the mechanism for that, or how we can explain that we can produce lung injury when we are breathing? We need to understand that when in healthy or normal lungs, we have this fluid-like behavior where the patient or is breathing, the diaphragm is activated, and the transition of the transmission of the lung pressure are more homogeneous. Whereas when you have um, injured lung with some collapsed tissue, the transmission of the pressure is not homogeneous, actually is heterogeneous, and that's called the solid-like behavior. So we will have higher pressure, in this case, higher pleural pressure in the surrounding area of the collapsed tissue. So this put more risk of lung injury in these areas, especially in the dependent lung areas when the diaphragm is activated. We also said that the pendulum phenomenon may occur. We understand pendulum as the mechanisms of exchange of air between non-dependent and dependent lung areas. This is a really nice study just published this year, last year, 2023, where they measured pendulum by the change of volume in percentage from non-dependent to dependent. And importantly, this author said that the magnitude of the pendulum is associated with respiratory drive and the effort. So the higher the effort, the higher the magnitude of the pendulum, and therefore the higher the risk of have some high stretch, high stretch lung regions, high stretch in some areas of the lung parenchyma and potentially further lung injury. So what happens in terms of the diaphragm? We said that excessive or low inadequate effort can cause some injuries. So we have some specifically three mechanisms where the diaphragm or the effort can cause diaphragm injury. The first one is the very well-known over-assisted myotrauma, because if we have very low efforts, it's highly likely that the diaphragm will lead to, or will cause, will have some disuse atrophy, we will have some myofibers damage because of disuse. So it's really important to maintain some adequate effort in order to avoid diaphragm atrophy. On the other hand, if we have excessive effort, we will have this under assisted myotrauma, And this is because we have excess muscle loading. So there's some data saying that if you have excessive muscle loading, especially the diaphragm, you will have sarcomeric disruption, and at the end, you will have diaphragm weakness due to this injury. And there is another kind of sort of new mechanisms where the diaphragm can be impaired, and this is the mechanism eccentric myotrauma, which is occurs mainly when you have some patient ventilator dysynchrony because of eccentric contraction of the muscle. So in this case, some dysynchrony may activate the diaphragm when the diaphragm is lengthening. And then we have some dysynchrony like a reverse triggering, premature cycling, ineffective effort that you will have this kind of situation when you will have an activation while the diaphragm is lengthening. And then there are other mechanisms. This is the expiratory myotrauma, which is not related to the effort, it's more related to the end expiratory, the level of. So if you want to plot how is myotrauma related to respiratory effort, you will have this kind of graph where the risk of diaphragm injury has a U shape. And if you have a very low breathing effort and you will have function impairment, you may have disuse atrophy, and also there is some clinical data that you can have a longer duration of mechanical ventilation. And on the other hand, if you have really excessive effort, you can also have sarcomere disruption because excessive loading. You can also have inflammation in your muscle, neutrophilic infiltration is the most common thing. But also clinically, you will have a longer duration of mechanical ventilation. So this is why it's important to control the breathing effort. And in terms of patient ventilator desynchronous, it's really important to understand the breathing of effort because the pathophysiologic and the cause of this kind of interaction is really different when you have high or low effort. So again, you may have this kind of U shape where at low level of effort, you may have reverse triggering, delayed cycling, ineffective effort, and many others. Whereas when you have an excessive drive, patient breathing very excessively, you may have this kind of desynchrony like a flow starvation, short cycling, and double triggering, which is pretty very dangerous to the lung. So, having said all of this data, we can say that now monitoring breathing effort is crucial to detect different excessive or insufficient level of breathing. Therefore, we can prevent potential complications and promote lung and diaphragm protective ventilation. So the next question is how we can monitor the respiratory drive and the breathing effort. And to understand that, we need to first look at the neuroventilatory coupling. So every time we can breathe, we need to understand there is a different steps starting from the central nervous system when we have our brainstem and the respiratory drive, and then other phrenic nerve, diaphragm extension or devalorization, and then you have the diaphragm contraction, chest wall and lung expansion, resulting in this kind of airway pressure, flow, and volume that we usually observe at the clinical practice. So understanding the neuroventilatory coupling, we can measure the drive and the breathing effort at any of these levels. That would be the ideal thing or the optimal thing to keep in mind. So where we can measure in the neuroventilatory coupling. So The thing is that we cannot measure the respiratory drive directly. We would like to know what is happening in our brainstem, but we cannot know. So in the clinical practice at the bedside, that we do is that clinical evaluation. We usually see clinical signs and breathing patterns, for instance. But the problem of these, they are very subjective, they are very variable, and they are not really sensitive to detect if the patient is breathing in high levels or low levels. For instance, some people say that you can look at the tidal volume just to see if patient is increasing the respiratory effort, but you know that tidal volume is the end of the neuroventilatory coupling, so it can be affected by different factors. You can improve your compliance, you can recruit some lung regions, and then you will increase your tidal volume at any given effort. So they are not really sensitive to measure the effort. So that we need to look at other things, for instance, the diaphragm electromyogram, electrical activity of the diaphragm, which is in the middle of this neuroventilatory coupling. And at the end, we can assess the mechanical output, which is at the end of these pressures and volume as a result of this contraction. So what's the most or the reference technique to assess the breathing effort is the esophageal pressure. For those who are not familiar with this tool, to assess the esophageal pressure, you need to insert or put a catheter in the esophagus, and then you need to inflate a balloon so that you can measure the surrounding pressure of the esophagus. The good thing about this is that this pressure is a good and well validated surrogate of the pleural pressure. And this is really important because we can estimate and derive different parameters. For instance, and probably the most important one in terms of the mechanics and to estimate potential lung injury is to transpulmonary pressure. So we know that transpulmonary pressure, which is the distending pressure of the lung and therefore the risk of lung injury, is estimated by the alveolar pressure minus pleural pressure. And during mechanical ventilation, we have the airway pressure the alveolar can be replaced by the airway pressure. And because we have esophageal pressure now, we can replace the pleural pressure. So that having esophageal pressure, we can estimate the transpulmonary pressure. And this is really important as I said before, because if we don't have this kind of tools, we can have or we can be losing some of the unseen effects of the breathing efforts. So here you can see volume control and pressure control during different breathing contexts. You have passive and active in both ventilation modes. And interestingly, you see that how the airway pressure minus the esophageal pressure can estimate transpulmonary pressure. And let's say that, for instance, in pressure control mode, if you don't have this kind of tools, you will see that the airway pressure is equal, there is no difference between passive and active. But when you have this deflecting pressure or negative pressure in the esophageal, now you can estimate, and actually the transpulmonary pressure is way higher that in a passive condition. So it is really a good tool to estimate. What are the values that we are thinking about? This is injurious. Well, we actually don't know, but Some literature and some observations are saying that probably keeping transpulmonary pressure less than 20 would be a safe cutoff to avoid potential lung injury. We also said that with esophageal pressure can derive different parameters in terms of the swings based on observations of what people or how people breathe during quiet breathing at rest. Usually, the swing of esophageal pressure would be between 3 and 8 centimeters per water. We also, with the esophageal pressure, can calculate the muscular pressure, which is the pressure that the inspiratory muscle are producing to breathe. This is can be computed by the difference between the chest wall elastic recoil minus the esophageal pressure, and some values between 5 and 10 can be an adequate effort. Using this esophageal, and if you calculate the time integral, then you can calculate the pressure time product, which is a very well variable to estimate the breathing effort. Actually, it's one of the gold standard because it's correlated with the oxygen consumption. And if you correlate and what is happening with the pressure and the volume, and you use the Campbell diagram, you can estimate the work of breathing that is measured in joules per minute. Unfortunately, the esophageal pressure has some limitations. It's not widely used because you require some expertise to put the catheter. You require some specific monitors and equipment to get the data, analyze the tracing. So probably one of the limitations is not widely available. One of the other invasive measurements is the electrical activity of diaphragm. Probably is also considered a good standard to and its most precise estimation of the respiratory drive because it's closer to the central nervous system. So the thing here is that you put a catheter in the esophagus that it has some electrodes. It reflects the crural diaphragm activity. So every time that the diaphragm is depolarizing and is activated, this electrode sends this kind of activity and process the signal. And the important thing is that these values are really variable between individuals. Okay. So every time that we can have the chance to put a EDI catheter, we also need to be aware that we can measure amplitude, so the peak and minus the baseline value, but we can also have the duration of the contraction, and also we can calculate the area under the curve to estimate different efforts. In terms of reference values, we actually they are uncertain. These are super variable, and you can have a huge range between 5 to 20 microvolts. So we need to you need to standardize by muscle pressure. Then you can calculate how efficient is your breathing. And similar to esophageal pressure, it has some limitations because there are some filtering that the algorithm is applying. For instance, they are you can have a flat tracing because of the filters, and this could be complicated because if you want to assess, let's say, a patient ventilator interaction, and because of the filter, the activity of the diaphragm is starting or is beginning delayed, then you can interpret this as a patient ventilator, as a reverse triggering, for instance. And that's why you need to be aware of some filters are applied. The other thing is that accessory muscle are not accounted. It means that you are only observing what is happening with the diaphragm activation, but we know that sometimes during the excessive effort, for example, you will have more muscle recruitment or other inspiratory muscles. And importantly, you need a specific equipment. You need the one of those ventilators, the Servo I, Servo U, to get the process signal and see what is happening with this EI. Here you can see a summary table showing the specific techniques for the parameters, the ADI parameters, the neuromuscular efficiency index, some values. So now you can review that. And nowadays there are more efforts to understand how surface EMG of the diaphragm can be used in clinical practice because it's non-invasive. So hopefully we can have these more available soon. So when we thought about different catheters or gold standards way to measure effort, we realize that they have limitation, they require expertise, and they require some specific equipment. So the question now is there any easier way to assess the respiratory drive and respiratory effort? And the answer is yes. We can have the tools that we have at the bedside with the ventilator, and we can use some inspiratory and expiratory holds. So the during assisted ventilation, we can also have this inspiratory pause. We are really used to use this kind of instruments or tool during passive mechanical ventilation, but during assisted mechanical ventilation, we can also use the inspiratory pause. The important thing is that if we have some effort and we use and we make an inspiratory pause, it's highly likely that the plateau pressure that you will obtain will be higher than the maximum inspiratory pressure that you set. This is because that the relaxation of the inspiratory muscle will be reflected in the airway pressure. So this is important to keep in mind that highly likely when you have an effort and you use a plateau pressure or inspiratory hold, this will be higher than the maximum inspiratory pressure. Using this tool, you can also have the pressure index, muscular index. That is the difference between inspiratory pause and the maximum inspiratory pressure. I'm going to explain this further here. So let's see a real example. This is from a nice letter in intensive care medicine published a few years ago. So you can review that in detail. So let's say you have this patient with a flow tracing in red, then you have the airway pressure in blue, and the patient is in pressure support. Let's say 10 to 5, people 5, pressure support of 5. And the good thing is that if you apply an end inspiratory occlusion, you will see how this plateau pressure will be way higher than the maximum inspiratory pressure. So in order to calculate the driving pressure during this static or quasi-static condition during assisted ventilation, you need to subtract the plateau pressure minus PEEP. And in this case, it would be the driving pressure of the respiratory system will be around 16, which is way higher than the driving pressure that you were observing without doing the end inspiratory occlusion. If you also have esophageal pressure in this case, you can have the dynamic or the dynamic distending pressure, which is the red arrow here, and it's around 18. And as I said, you can also calculate the muscular or the pressure muscle index, the PMI, which is the difference between the end inspiratory plateau pressure and the maximum inspiratory pressure, which in this case is around 10 or 11, and is the difference between 21 and 10.5. So what does really mean? There are some studies trying to interpret and see what this value mean. So just to get zoom in one breath, you can have this driving pressure during assisted ventilation. You can have this PMI, plateau minus peak, and you can have these values. What this PMI means, there are some old studies trying to understand or trying to determine a cutoff value, and it seems that PMI around 6, 7, it can well discriminate the high or low effort. In this study, they use the PTP, the pressure time product, and they say that a PMI of 6 can well differentiate those with high or low breathing effort. And in the right side, you can see how the muscular pressure is well correlated with the PMI value. Importantly, when we use inspiratory pause during assisted ventilation, we need to be aware of many things, especially the plateau pressure that we are observing. Um, it, it should be well done, let's say 2, 3 seconds, uh, just to because we need to allow the relaxation of the respiratory muscle. Flow must be zero. This is really important. It might be really stable. It doesn't, it's not good if you have a plateau pressure going up or going down, or if you have an effort between or in the middle of the plateau pressure. I mean, it doesn't mean that you cannot use it, but at least you need a sort of stable time with this plateau pressure in order to use it and to be this maneuver valid. Okay, here you can see the table with many considerations published, and that's the reference, so you can review it in detail. But in general terms, it needs to be very stable and without any artifacts. The other pause that we really use in clinical practice is the expiratory pause. There are some recent studies validating the delta in the airway pressure during an expiratory hold. And it's nice because they validated this maneuver to estimate or to predict the PMAS, to calculate the breathing effort, and also to estimate the lung stress based on this dynamic change between the airway pressure. So after several validations, the authors came up with a sort of formula just to calculate the predict PMAS and to the predict delta PL. Here they got a factor, which is 0.75. So you need to first calculate the change in the airway pressure and multiply this for the factor. So just to give you an example, how would be this? You have this formula, you have you can make an expiratory hold, and then you measure what is the delta POC, and then you need to multiply this for 0.75, which is the constant or the factor that they use. If you have an expiratory hold and then you have no change in the airway pressure, that would be a delta POC of 0, so the predicted PMAS is 0. Let's say an excessive effort, so you make an expiratory hold and you can have this minus 30 change in airway pressure, then you will have a predicted PMAS of around 23. Whereas if you have a small drop in the airway pressure, around 5 centimeters of water, you will have a predicted PMAS around 3.8. So the good news is that this tool, which is the Delta POC, has a really good accuracy and prediction values with the area under the curve to predict excessive PMAS, more than 10 centimeters of water, and to predict excessive delta PL, um, in this case, greater than 15 centimeters of water. There is more tools available in the ventilators. This is the airway occlusion pressure of P.1. Is the airway occlusion pressure during the first 100 milliseconds. The good thing is it can represent or reflect all inspiratory muscles. This is really good because it's an unconscious reaction, so the patient doesn't realize that there is something happening during the first 100 milliseconds, so it can reflect the respiratory drive. It's independent of the respiratory mechanics, so it doesn't matter if you have very low, high compliance. Usually, it's independent because it's the very first milliseconds. It's unaffected by the condition of the muscle. There's some nice physiological studies showing that. And as I said, it's available in almost all the ventilators. So when we look at some values now, we have some studies showing that we have values from 1 to 4 in terms of the reference. It means that if you have a very low value, you have a really low effort, but you have very, let's say, values around or above 6, you may interpret that as a really high effort. Is this a really good predictor for low and high effort? There is a nice recent study a few years ago trying to validate the P.1 against different gold standard breathing effort measurements. In this case, the PTP or pressure time product, and using different cohorts of healthy subjects, patients, and they found really good correlations, a really good area under the curve, just to estimate low and to predict low or high effort. There are some limitations with this. Patients with hyperinflation, sometimes P.1 can be underestimated. And some ventilators, they really don't do the maneuvers. So they just measure the drop in pressure during the breathing or during the trigger phase. So probably that would be an underestimation of the P.1. We can also use these techniques of delta POG to differentiate between some patient interactions. For instance, you have this reverse triggering or double triggering. And the idea, if you understand that reverse triggering usually is in the low, is in the pathophysiology of reverse triggering is with low drive. And if you make an expiratory hold, you will see probably nothing. But if you have a patient with excessive effort and you make an expiratory hold and see this double cycling, you probably understand that this is double triggering and not reverse triggering. And also, just to differentiate this kind of interaction, you need to see and look at the first cycle, which is triggering the vent. During reverse triggering, you won't have this kind of drop in pressure, whereas in double triggering, you will see that the patient is triggering the vent. More techniques, more and more people are using ultrasound to measure diaphragm activation, diaphragm structure. There is one measurement, an index, which is the thickening fraction, that can be really well associated even with some outcomes. There's a nice study showing that you need sort of normal thickening fraction between 15 and 30%. And if you have low or more or higher thickening fraction, it can be associated with duration of mechanical ventilation. So this is a really nice and non-invasive technique that uh, clinicians are using to observe how how the diaphragm is functioning. So, what should we do in terms of the clinical practice? We know that diaphragm effort or measuring or monitoring diaphragm drive and effort is important. So now we need to start worry about not only respiratory homeostasis, we need to protect the lung, but also protect the diaphragm. We need to maintain some modest respiratory effort, avoid excessive effort, and hopefully maintain synchrony with the idea that if we protect both organs, probably we will have better outcomes in our patients. So here there's some potential targets, values for safe spontaneous breathing. So if you have esophageal pressure, then you can derive different parameters. So end inspiratory transpulmonary pressure less than 20, swings in transpulmonary pressure less than 15, PMAS between 5 and 10, esophageal pressure swings between 3 and 8, pressure time product 50 to 100. And then if you don't have the esophageal pressure, you can use the occlusion maneuvers. So the idea of inspiratory occlusion for plateau airway pressure, that would be great, less than 30, that's the passive condition rate. Inspiratory occlusion for driving pressure, less than 15. And in order to estimate TMAS, expiratory occlusion between 5 to 10 and P.1 between 0.5 and 3.5. EMG on electrical activity of the diaphragm, actually, we don't really know. So we need to keep doing research to better understand that too. Which strategies can we use? Well, you know that um, we can modulate the breathing effort using different variables. You know that if we increase ventilatory support, usually we'll decrease the breathing effort. So, but you need to be aware that if you have excessive or over assistance, you may have atrophy of your muscles. Same with sedation. You can try to modulate the breathing effort with sedation, but if your patient is too sedated, probably you will impact the outcomes. PEEP, there is some current evidence that PEEP can affect the respiratory drive and the effort depending on the compliance. If you recruit some areas with PEEP, probably the drive of patient will decrease, and also you can alter the geometry of diaphragm, so your drive and your effort will be modified. You have some others strategies like neuromuscular blocker. There's some pilot studies showing that can be an option trying to use this strategy to modulate, and some extracorporeal CO2 removal as well. Just to show you one example, there is some emerging evidence trying to test this kind of strategies to protect lung and diaphragm. Here, the authors try to put some targets in the transdiaphragmatic pressure. So they say our target is around between 3 and 12. So if you have this kind of pressure, okay, no adjustment, but if you have very low PDI, then you need to reduce your support, or if you have very high PDI, you need to increase your support. And some safety criteria, they were observing plateau pressure and of course gas exchange and pH. And then they were trying to maintain this for 24 hours. And the good thing so far, this was a feasibility study that with this strategy, with very close monitoring, they have higher percentage of breath within diaphragm protective range. So it means that a very close uh, look at the patient with these kind of things, it might protect more patients, but still is very preliminary. We need more data to understand these kind of strategies. So just to conclude, um, we need to know that the monitoring of dry respiratory effort is really important to prevent some potential risk on lung and diaphragm due to inadequate effort. Um, we know that now we have various techniques, can be either invasive or non-invasive, to monitor respiratory mechanics, drive, and respiratory effort, even during assisted ventilation. We know that the drive and the respiratory effort can be modulated by various ventilatory parameters and pharmacological strategies. But still, we need to do more. The impact of these strategies trying to protect both organs are uncertain, and we need to do more research to see what happened in with the outcomes of patients. So thank you very much for your attention and happy to have some questions.
Thank you very much, Professor Damiani. This was great, very insightful. And I'll remind everyone as well that you can keep posting questions on the Q&A, and we'll see them as we go along. I do have a few questions to start with. So first one is, what values of P.1 and delta P occlusion are usually used in clinical practice?
So yeah, I think I said a little bit about that. So in terms of values, um, you know, people in one is really good to discriminate between low and high effort. So if you have a value less than one, you can assume that your effort, or the effort from patient is really low. But if you have more than 5, 6 centimeters of water, also you can interpret that as a very high or excessive effort. And in terms of delta POC, or occlusion pressure, usually between 5 and 10, with that conversion factor of 0.75, that would be an adequate effort so far. There's limited studies validating this, so still we need replicate to be more certain. But so far, between 5 and 10 of delta POG, that would be okay.
Okay, thank you. So the next one, in the lung and diaphragm protective ventilation, um, which one should I prioritize? So I guess between the lung and diaphragm protective ventilation.
Sure. Okay, so this is a really nice and important and unsolved question. For decades, we've been focused on lung injury. So most research has been focused on how to protect the lung, how to decrease lung injury, how to decrease airway pressure, and that's why we have the low tidal volume protective ventilation, and we have known a lot. But in terms of the diaphragm, there is just few years of research. We now are more aware that this is important and we need to protect also the diaphragm. Uh, that's why now we are trying to protect both. But if we have to decide, probably people are dying because of lung injury, not because of diaphragm injury. So actually, the guidelines of papers about lung and diaphragm protective ventilation, they also conclude that if you need to prioritize some of the organs, probably protect the lung and see in that context how you also can protect diaphragm.
Okay, makes sense. I've got another one. Are patient ventilatory desynchronies a real concern in lung and diaphragm protective strategy?
Um, Interesting. You know, uh, that patient ventilator desynchrony is like a complete world. We have many types. We have different mechanisms behind. So you will have desynchronies with low effort. You will have desynchronies with high effort. So it's really we need. I would say we need to start um, to differentiate which type of patient ventilator desynchrony we are talking about, because it's not the same reverse triggering versus double cycling. It's not the same ineffective effort versus premature cycling, and so on. So my first point is, um, let's start talking about different types of desynchrony and see how this specific asynchrony affects lung and diaphragm. So, in terms of the evidence, I would say there are some associations between patient ventilator asynchronous and outcomes. However, we don't know if this is a causal relationship or is only an association. In my experience, working and doing some research in reverse triggering, we have found very let's say, um, opposite results depending on the level of breathing effort. For instance, we did some preclinical experiments with to assess the reverse triggering impact on diaphragm structure and function. We found that if you have reverse triggering with excessive effort, you can have diaphragm injury and you can have an impaired function of the diaphragm. But on the contrary, if you have reverse triggering with very low effort, actually you can preserve diaphragm function compared to passive ventilation. So it seems that we don't know yet if patient ventilator asynchrony are affecting or are really an issue in this kind of strategy. And I think we need to still understand better which type of asynchrony and how those different types are affecting lung and diaphragm in order to get a more complete vision of the problem.
Okay, thank you very much for that. I mean, that's all we've got in terms of questions for now. So at this point, where I'll say I'll remind everyone as well that this webinar, as well as everything else in the buyer page in the box, can be replayed and reviewed at any time. Many thank you for your participation, Professor Damiani. Many thanks for doing this very insightful presentation, and we hope to see you again in the next buyer webinar. Thank you very much and goodbye.
Thank you so much. Bye bye.